stent next, because plastic stents are not
Or
working.
you can go for Costa Magna protocol.
Yeah, multiple plastic.
multiple
Anyway, we have always
stents.
put two, three only we have put. Not a single stent, we have never put a single stent. Always we put 2, 3 stents.
You can also ask another opinion on cytology.
Yes.
Yeah.
If that somebody else, an expert pathologist, looks at it, says it's all artifact, then that makes your life easier.
Yeah, the relatives have taken all slides. They will go to another center. So this was my last case. So if there is any other question from the house. Final comments like from the panelists.
I think in practice, there is a problem of intermediate biliary stricture. I mean, still we don't know how to approach them. I mean, the protocols or the recommendations are not clear. I think with cholangioscopic picture and biopsy, it may add further. Yeah.
So this is a protocol for indeterminate biliary stricture, which I skipped. So here they have written, if there is indeterminate biliary stricture, review cholangiogram and previous imaging. If it is a proximal stricture, ERCP with repeat brushing and cholangioscopy with biopsies plus confocal laser endomicroscopy probe based. If it is positive, go for surgery. If negative, then again you can repeat one more ERCP with brushing plus fish plus cholangioscopy biopsies. You can repeat confocal and laser endomicroscopy or intraductal ultrasonography. Then if it is positive, again same. And if it is a distal
Now at
stricture,
our center we have this intraductal US available. So now we can do that also.
intraductal, yeah. So next, even if it's a distal stricture, then it is a bit easier. We can do US FNA. We can repeat US FNA, and if it is positive, then you can do.
Thank you, Dr. Sandeep. Now we will move on for the live demonstration of cases at OT. So can we switch over to OT2? Over to you, Dr. Yogesh.
Good afternoon, everyone. So now we move to OT2, where we have done laser lithotripsy just 3 days back. But honestly, we could remove 80% of the stone. 20% of stone is still impacted inside. So Dr. Mukesh Kala will be demonstrating stone breakage by laser lithotripsy. And along with him, we have Dr. Naveen also. We have other 2 cases in which there is a biliary stricture, which we will take biopsy as well as negotiation of the wire for failed ERCP. And last case would be migrated stent removal. So over to you, Dr. Mukesh Kala.
Thank you so much for the invitation, and thank you so much for entrusting your difficult patients on us and belief on us that we will be doing justice. So coincidentally, as Dr. Goenka had mentioned in morning hours today, that they have had a study, multi-centric study, where radiation-free ERCP, that is what he said. So we are going to do a radiation-free ERCP for a change. We are not going to use the C-arm.
Why, sir?
We will not use the C-arm, because we know that there Yogesh has already done a wonderful, nice, wide sphincterotomy. So we are going to use the cholangioscope. We'll go inside, and I was told by my Kamal and Manish have told me that the EHL was done for this patient earlier, and there is probably some large fragments still pending inside. So my task here is to go in. I am not going to get a support of a cholangiogram, but I think that's the beauty of this procedure. I mean, because Yogesh has already done a good sphincteroplasty here, so I don't think we should face a problem. लाओ स्कोप ले आओ, कोलेंजियोस्कोप ले आओ सीधा. अच्छा तुम्हारे कोलेंजियोस्कोप के कनेक्शंस हो गए?
I think as we discussed this morning, so hi, this is Naveen here. So as we discussed this morning, I think putting as much little contrast as possible would be the right thing to do. If you give contrast, and you will get viscous views, and then your views will be compromised. now that we got a nice big sphincterotomy done, we should be able to get this pi scope straight away.
Wonderful.
Excuse me, to moderate the session, I'll please invite the moderators, Dr. Narendra Sanghvi, Dr. Saurabh Mukhewar, Dr. Kaivan Shah, and Dr. Ishan Shah.
So are we audible in the theater there?
Yes, hi, thank you. You're audible.
So,
Good
Yogesh,
views.
are they, what kind of stones are there? Are they pigmented stones or yellow stones? Pigmented stones, yeah.
There are fragments outside.
So most of the times if you have yellow cholesterol stones, with the softer stones, they will come out easily. Often when you have a bigger pigmented, black pigmented stones, that's where you find difficult to break the stones. And that's where I think spyglass definitely, and EHL will definitely help us out.
So did you get a cholangiogram before you started or not?
No, we didn't do any cholangiogram. We're just going, this is a nice wide sphincterotomy was done.
This is going to be a radiation-free procedure today.
The cell stones, yeah.
I think, yeah, that's a good
You
idea.
can see some pus as well coming out, I think, on the spy scope. Yeah, there's the stones.
पानी आ रहा है क्या? दिख नहीं रहा है. अब आया. So this is not a very ideal situation, but we'll spend some time in clearing the vision. There are few pus flakes there because they will interfere with the working here.
It almost seems like sort of fibrotic strands or so. Okay.
So before we start with the laser lithotripsy, I would just like to seek your attention. ये focus करना जरा इधर ना, इधर आओ, और तुम इस fiber को नीचे डाल लो इसके अंदर. So is this screen visible to you here?
Yes, we can
see,
see.
Yeah, this is a lithotripsy machine, is a holmium laser lithotripsy, which is a 30-watt holmium YAG laser. So the two things which are very important to learn here is that this has got three kinds of modes. The one mode is called a hard stone mode. The second mode is called dusting effect, and ablation and coagulation are of no use to us for this particular case. So when you have a very hard stone, then you start with a hard stone mode, and when you are fragmented, then you stay between the fragments and you start with the dusting mode. So it's going to make just पानी डालता ही रहे. So डालता रहे पानी बीच में. So what I am going to do now, that what you need to understand is that above is 0.5 joules and down is 3 hertz. So when you multiply 3 hertz with 0.5, it comes to 1.5 watt energy. Then we have three types of fibers available with us. One fiber is 200, other fiber is 272, and third fiber is 350. So our GI fibers are usually 200 and 272. So up to 12 watt energy, 200 fiber is good. But if you want to use more energy, then you should use 272. These are two fibers which will go easily through the cholangioscope. The bigger one is a urology fiber, which will can pass through a cholangioscope, but then it will need a struggle while manipulating this fiber at the point of ampulla. So what I am going to do, what is my philosophy on this, we have learnt it from our urology colleagues on this issue. First we'll go and see a patient, go and see the stone, and initially we will keep the frequency high and joules low, and we'll keep it on a hard stone mode. Once we have disimpacted and when we have broken the outside shell of the stone, the inner shell will be more hard. So what I will then increase the joules, the energy, and I will reduce the frequency of the machine. So I will work around 8 to 12 because I am going to use a 272 fiber. So I am going to work around 10 to 12 watts energy for breaking the stones. पानी डालता जा.
थोड़ा
So
सा
another
down
thing
देना.
here is that two fibers and arrangement of the machine. Initially we go with high frequency, low joule, then we increase joule and decrease the fiber. Paint and brush, this is what the urologists say and when they are working. So we are not going to touch the stone with the fiber. Our intention is to stay 2 millimeters away from the stone, and we will keep on moving left, right, up, down, and keep breaking the stone. If you go and touch the stone and then if you fire the laser machine, it is going to create a bore or a hole inside the stone, which is not a very good situation, because after that, if you enter inside this hole kind of a thing in a stone, then the energy is not adequately transmitted, and then there is a problem. So therefore, I mean, stay 2 millimeters away. There is a pilot beam which we will show you right now. This is a one good, very interesting thing in these laser machines, which will focus where the energy is going to go and get in touch. This is a non-contact fragmentation of the stone. So Naveen is here to help me out, because I am not a single operator cholangioscopist. I am a double operator cholangioscopist. Unlike West, where there is probably want of gastroenterologists, here my colleagues will never mind helping.
So Dr. Kala, thanks for the excellent talk on the laser. I personally use 365. I know it's a little harder to get across, but I
Yes.
think can deliver more energy, especially with these
Yes,
stones
yes, yes.
oftentimes are hard.
Yes, if
So
you have a
unless there's
large,
a soft
Saurabh, if you have
sludge
a
ball,
very
then I
large
think it's
stone,
okay.
if you have a very large stone, if it's a hard stone, you can go ahead with 365. The only small precaution which you need to take when you're using a 365 fiber, then get it out first before you enter inside the common
Yeah.
bile duct.
We
Once
agree.
your elevator is on, then it becomes a little challenge in negotiating the, the fiber across the 1.2 mm channel. पानी डालो, ये पस हटाओ, पानी डाल.
And just your comments on the hertz and the energy delivered. So I think some other laser systems have a total energy delivered
no.
as a variable where you can directly choose the number of watts. I think it's sort of variable between the machines.
आया क्या बात?
Laser, huh?
Watts,
So,
Saurabh, there are three kinds
Yeah.
of machines available. The lowest is 15 watt machine, then is 20 watt machine, then is 30, and then is 50 watt machine.
थोड़ा सा
So
tight है
usually
यहाँ
for
पर.
even
Yeah.
for urologists and for us, I mean 15 to 30 watt is good enough. In fact, 15 is
Right.
adequate. If you have 30, then if you use 365 fibers, you can even break the bigger stones and the harder stones also.
Just a bit
Yeah,
of
I think-
resistance
I
to the
think
laser.
now-
I think it's just at the bridge पे होगा
All
शायद.
right. So
Yeah, we agree.
we
I
are-
think it's never really ever required to use 30 watts.
Yeah, I
Max
don't think we
250 to
will ever
20
need
you
30
should
watt
be-
energy. In fact, we should not rather, because
Yeah.
I mean we'll
Tissue
probably
damage,
invite
yeah.
more risk with creating
Yeah. it's-
perforation and bleeding. So I wasn't able to take 272 fiber out of this scope, which this scope has been used only third time.
बंद कर दिया.
So now you can see the fiber.
On कर दीजिए.
On kar do.
I just left it at the tip of the spy scope, the laser probe. थोड़ा सा पीछे ले लो उसको.
चलो पानी चलाओ. आप पानी
Yeah.
चलाओ कमल जी. अच्छा ठीक है.
Yeah, just doing
Naveen,
it, yeah.
Naveen has the irrigation in his hand.
Yeah.
So now I want to seek your attention to very important. सुनो इधर आओ. Now, if, our purpose, because we are a poor country and we need to save the scope and we want to use it as many times as possible. So try and use the up and down knob. If you see, is the cholangioscopy picture in front of you?
Yeah, we can see it. No,
All right.
it's good.
So when I'm moving the up and down knob, you can see this the stone is going nearer and irrigation on karna.
Yeah. Continue.
So let's have a better picture. So up and down, it comes closer and it goes away. So instead of using the shaft of the cholangioscope, it's better to use up down knob. And now pilot beam on karo. So now
No, I
we
think
have
that's a great demonstration. I think that's really important. Thanks for showing that. Where you can actually have a lot of movement without bending the scope too much, you can then really
Yes.
make it last longer.
Fiber आगे के बाद.
Yeah.
I also tend to sort of move it clockwise, counterclockwise, my hands,
Yes.
which I guess gives a similar movement as the
Fiber नहीं
dials,
जा रहा.
but that's nicely shown.
नहीं आ रहा, fiber नहीं आ रहा.
फिर से नहीं जा रहा. Just
चलो, अब
gently
डालो, अब
pushing it in.
कोशिश करो. थोड़ा बाहर निकाल के रख लो. थोड़ा बाहर निकाल के रख लो.
Yeah.
बस थोड़ा सा कम कर लो.
That's
थोड़ा सा
enough,
कम
no?
कर लो. हाँ, little bit less. So we were struggling with taking out fiber when we were inside the common bile duct. So we came out. We brought this fiber right at the tip of the cholangioscope, and now we are going back inside the common bile duct.
1 minute फिर से नहीं जा रहा.
No, it's
not-
there. It's there. It's
Yeah,
there.
yeah, I can see it now.
Irrigation on रख लेना.
Yeah.
Yes, pilot beam on करो. थोड़ा सा पीछे ले आओ.
Yeah, I'm just pulling it slowly.
Yes.
Yeah.
Now, कितना वोल्टेज रखा है? हाँ, अपन 8 वॉट रख लेते हैं. कितना आ गया? ठीक है, good enough. So this is a big advantage of this laser machine because it's going to fire on the pilot beam. This greenish tip which you can see here is the place. Fiber दिखाओ. बस, perfect. So now my setting here is I am going to use 15 hertz, frequency of 15, energy of 0.5, and we'll see how it behaves like. So this is how it works. And the important thing is that the irrigation should stay on because it creates heat there. If you don't use regular irrigation, then you can lose the fiber. You can create injury to the mucosa also if you get misled. It's very, I mean, it's just like you don't need any big learning curve for the procedure. Small tricks you just have to keep in mind. And tricks, if required, if I was in US, I would probably not need any tricks because I will throw away this cholangioscope after the procedure. But since I am in India, I need tricks to save my scope for at least 10 times use.
I think it broke now.
10
Yeah.
times is very
It broke.
optimistic. But yes.
Wish we can do that.
Yeah, it's nicely pulverized now. You can
That
see
looks
it.
like. Now, Saurabh, the machine has big another advantage. Nirav, tell us about popcorn mode for the scope. You have that in this? You can do that. Explain that. So we have an engineer from the laser machine. So he is going to tell us about a new mode of laser lithotripsy, which is called a popcorn mode. So what happens that when your corn is inside, and when you switch it on, then it will keep bubbling all around, which is a partly kind of a dusting mode. When you cannot control, then you can use a popcorn mode to do a dusting.
Yeah, sounds like a good mode.
Yeah, which is, I mean, the laser quanta people have labeled it as a popcorn mode, and I have often seen the urologist people using it very frequently.
Yeah, and I think ultimately,
Are you still there?
Pani chala.
a goal is
Yeah.
to not have a
That's
dust
ongoing.
and small dust coming out. It's just the fragmentation which is the goal.
Looks like a
Yeah,
stone.
that's
If
the
this
system,
can
that's
be
the stone.
accomplished faster,
Yeah, yeah.
it makes sense to use this mode.
So can you see this is the hard core of a stone?
Yeah.
Hello,
Yeah,
right.
you can
Just
see
it.
that.
Throws a fiber again. And another important thing is that while you're doing this laser lithotripsy, this blue thing, the covering of the fiber should always stay in your vision. By any mistake, if you start firing within the scope, then your scope is gone, you are down by 1.5 lakh rupees.
Yeah, I've been there. It pains.
Yeah.
Yes.
So always ensure that while you are firing, the blue thing, the blue plastic covering on the laser fiber should be in your view. If it is not, then there is 100% probability of losing your scope.
It's just like APC probe, isn't it?
Yeah,
You
it's
want to
just
see,
like
you want to
APC
see the
probe.
black part of that and the blue part of the
Correct.
APC probe.
Correct, well said. And when at this point of time when your stones are just floating and kicking all around, which would probably mean that most of the stones have become very small.
Pulverized, yeah.
You should do more suction here for two reasons. That
One
you'll-
stone sticking
if you,
out
If
already.
you do suctioning, then these stones.
I'm just sucking. I'm just sucking up.
अच्छा suction भी हो रही है क्या?
Sorry.
Irrigation करो. हाँ.
Yeah.
तो मैं I will not fire. It's in my hand. Stand by क्यों करते हो? हाँ हाँ नहीं 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 ऐसे कैसे? Out of question.
Shall we just
नहीं
go?
ठीक है understandably correct.
Shall we go in a little bit and see if there's any
Yes.
more stones? I'll just pull back the probe a little bit.
No.
In there.
The most important thing is that you fix your position and don't play with the laser.
Yeah.
The whole movement will be either in your
In
right,
the right
left
hand,
knob or with me with
Yeah.
my endoscopy shaft.
Yeah.
We will only touch the laser fiber once it stops fragmenting. Another very important thing which I want to share with you for all those people who are keen on using this equipment, while you're pushing this fiber inside the cholangioscope, and if you face any kind of resistance, please don't do it, because in case if there is angulation which happens in the probe, then take my word that next fire and
Yeah. Fine,
this
yeah.
will blast, and it can injure also. So make sure that there should be absolutely no kink in the fiber. I'll have to go in a little.
Yeah. It almost made a hollow there inside.
Yeah. Which is not a fair thing to do. If you create a hole, is not a fair thing to do, which means your technique was faulty.
Why do you think it is a problem if you create a hole, Dr. Kala?
Saurabh, what happens that this is a wide hole, and it will only work, the laser fiber will only work if it is just 2 millimeters away from the surface which you want to fragment. So the best thing is to do paint brushing.
Yeah.
Paint brushing, this is what this is the paint brushing, na? So you keep moving like this, and these stones will keep fragmenting.
So you basically keep chipping it, and then from it,
Yeah.
it starts from the edge and it starts chipping from the edge, rather than drilling a hole. Yeah, you can see it nicely broken now.
But what you
Yeah, very nicely broken down.
थोड़ा सा
We
आगे
can
निकालो,
see all
fiber
the
भी खराब
fragments.
नहीं है, बस, हाँ. So my concern while doing cholangioscopy is always on the length of the fiber. I just don't want to lose the scope, because the day I lose scope, I feel very bad in the evening hours. There are, I don't want to say, but there were lucky scopes for me which lasted around 15-20 cases also. But you have to use it very carefully if you want to make it a really cost-effective equipment. And the biggest fear for a person who's doing who's going to start laser lithotripsy is that my laser is going to injure the common bile duct. So I really want to assure those people, unless you are really nasty, and if you don't realize and just you stand on the laser and keep your fiber right on the mucosa, it can. But normally at 10 watts, it is such a less energy that it will not create any perforation. So even a small amount of care is enough to.
That's true. I think the energy required to damage tissues by and large for ablation or cutting is about more than 60, 80 watts.
Yes.
Which is what the urologists use for TURP and stuff. I
Correct,
think they use
correct.
like a 100-watt laser or something.
Correct. Well said.
But then I think in terms of the, but I've still seen if there's a misfire and there can be some oozing from.
Yeah,
I've
that
never
happens. That
seen
happens.
a perforation, but there can be oozing
Yes.
if there's a misfire of the
Okay.
laser on the wall.
That sometimes happen. हाँ हो गया almost ना. थोड़ा
But
ऊपर
never,
जाके
never, never
पानी flush
to
कर
the
देते,
extent of
मलबा निकल
perforation
जाएगा.
and so.
Stricture है इसको. पानी 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 चलाना.
I don't know.
अच्छा. अच्छा यार ये हाइलर स्ट्रक्चर फिर तो स्टेंट हैज टू बी प्रॉपर.
Mm.
नहीं वो मतलब तुम्हारा स्टेंट है ना. क्योंकि फिर चक्कर हो जाएगा फिर. Well, if it is a hilum, then it is a relative contraindication for the procedure also. Saurabh,
Yeah, we can. Yeah,
tell me
please go
one
ahead.
thing. When you're doing a hilar biopsies or hilar cytologies, hilar, strictures, are you not afraid of giving ascending cholangitis to the patients?
No, I think that we were sort of talking about this in the previous session. There is a real concern of cholangitis in our Indian context when
Just
we are
need to
doing
check what
hilar
is there
cases.
in there.
And
Picture है
I-
कुछ देखेंगे थोड़ा.
Yes.
And my personal preference is I have a very low threshold for metal stent placement, which has a lower risk of cholangitis, and especially, and you know, nine out of 10 of these are going to be inoperable when they are
Yeah,
type
I'm just
4
continuously
strictures or
pushing.
so that's a real problem, especially tight strictures. And if you place plastic stents, you can't oftentimes get a 10 French stent in. So
Yes.
you'll end up choosing a 7 French, which is what mostly you get. 8.5 French stents are
No,
also
I will
not
be
very
sure to
widely
advise.
available.
I'll try and
So a 7 French stent may not really work that well.
yes.
And these patients have real issues with cholangitis. Although I think it's just the
Pani
ERCP
Chal raha hai,
itself,
pani
which
chal
is
raha
the
hai.
reason
And
for
on again.
cholangitis. I'm not sure if SPY really contributes much to it. But the ERCP, I think itself is more sort of the reason for cholangitis than anything else.
Yeah, my intention of intentionally raising this question was like if when you're doing a hilar stricture for any patient, like indeterminate stricture, and you're planning to do a, there is a stricture.
There is a
Yogesh?
stricture. There is a stricture.
There is a stricture.
Wow.
So we need to go above this.
Yeah.
There is a stricture. Should we take a biopsy because it looks there? It's done from here. You've taken a biopsy. Okay, and it's positive. Then
It's positive.
Okay. Then it's okay.
It
Then
looks
it's okay.
positive.
Yeah, you can. We are almost done. So we are shifting to the next theater, and before I mean,
just
for
put a
the
wire-
indeterminate stricture, I want to raise a point that you should discuss with your patient before doing a cholangioscopy, that they should be mentally prepared for stenting. It won't. I mean, the patient won't come out without a stent because there is a reasonably good risk, and you should have complete data in your hand about the nature of the stricture. It's type 1, type 2, type 3. आपको करना है.
Yeah,
There.
I think it's a good point. We always need to have roadmap of what we are dealing with cross-sectional imaging before we do these procedures.
ऊपर भी stones हैं.
There are stones above the stricture as well. But let's
Dr. Kalla, last question.
I'm just
Since we
getting
are
the
talking
wire
about
out.
the costly instrument, what will be the cost to the patient per procedure?
I am not able to listen. Can you repeat your question, please?
What will be the cost to the patient?
For a
Since it's a
cholangioscopy
costly
procedure,
instrument. Yeah, procedure.
I am inappropriate person to tell Sanjay Rajput if he is in the hall. He will tell you about Ahmedabad. But for Jaipur, it is 60,000 rupees.
Yeah, same, sir. In Ahmedabad also, same,
Yeah.
around 60 to 80,000.
Yeah, in Jaipur, 60,000 in and out. Else we do CBD exploration for you.
Oh, so sir, we move to next OT. I request Dr. Kiran to give history, and then Dr. Saumin will be demonstrating the
Lymph आ
case.
गया. Yeah. Stent डालेंगे. पहले stent डाल के.
हाँ, पहले stent डाल दो.
Yeah. Then we can. You want to remove the stone?
Live demonstration. Hello. Live demonstration for the case cholangioscopy and biopsy from biliary stricture. Dr. Saumin Shah sir, senior gastroenterologist, Gujarat Gastro Hospital, Surat. 70 case. I'll discuss a case. 75-year female with obstructive jaundice, MRCP seen CHD and hilar stricture, CT guided biopsy technically not feasible, plan cholangioscopy and stricture biopsy, other options also US guided FNAB, learning points, use of cholangioscopy for diagnosis the biliary stricture. Thank you.
Am I audible? Hello.
Yes, you are all audible.
Okay.
Thank you.
Hi,
Saumin.
I'm Dr. Saumin Shah. So as per I'm just demonstrating first time live spyscopy. So Murphy's law is applied. This patient has a D1 D2 narrowing. We are not this is a naive patient. We have cannulated it for first time even after pre-cut, and then we do a sphincterotomy and as well as the sphincteroplasty. And as sphincteroplasty, I personally feel it is necessary for the easy intubation as well as to increase the durability of scope. and we did a air cholangiogram. And can you see the previous IITV image? We did a air cholangiogram, and you can see in IITV image, air is going into the right duct and partially into the right anterior, or maybe in the left duct. And in previous we had tried to cannulate the wire, but we are not able to cannulate, and we didn't try too much also. So now our objective today is to uh, uh, how the you can differentiate from the benign to the malignant. I think the biggest use of the spyglass in the present era, which change the entire management, is to differentiate between the malignant and non-malignant first, and if it is malignant, extent of the disease inside the biliary tract, because if extent is too high, it will change the surgical management entirely. So I have already cannulated, we reached up to mid CBD, and if you see there is a slightly suction. If you see, there is a slightly already abnormal mucosa is there, vessels are there, so likely this is malignant by visual impression. Neovascularization, papillary projection, and abnormal mucosa all are suggestive of this patient has a likely a malignant etiology. But we try to go further, and let's see, give it to the Sandeep. Sandeep, please help me.
Yeah.
I personally feel as because I am not a very experienced in this procedure, and we are just started it before few months. So Sandeep is there to help me, and it will
flush karo.
flushed. Okay. So it will. So I can. You see the particularly the position from 9 o'clock to 3 o'clock. There are lots of blood and abnormal mucosa is there. Please keep it in center. Keep it in center. Okay.
Yeah.
So by as tip by most of the we are trying to go via movement of ERCP scope and just up and down knob rather than using an elevator. Okay, so I think please keep it in center. Lots of
Stricture.
we are in the stricturous area.
Yeah, I think Somin, I think this looks like a malignant stricture with the bleeding and fibrosis causing making your life a little difficult and in terms of visualization, which I think we expect as these malignant tumors bleed that cause all these sort of fibrotic adhesions to the wall of the bile duct.
Please keep it in center.
But as you flush in more water, I think you will be able to visualize it even better as you plan for biopsy. But I think good point, even in strictures that you should be doing papillo or sphincteroplasty to enable the scope to pass in without, much trouble as you have the spy forceps on tip of the scope. Not only for stones, but even for, which is how I have personally changed practice. We have done papilloplasties for all the cases getting into the bile duct, regardless of stone or strictures.
Yeah, this is the center actually.
So I think this is the narrowing. We try to.
Yeah, this is go ahead. This is the center.
Fluoro. I think we have reached up to hyla. Fluoro. Where is fluoro?
I think the stricture starts at the common hepatic duct itself, like this, even involving the proximal CBD. Fluoro.
I think it is mid CBD.
Yeah.
Yeah, looks like a mid CBD stricture.
Yeah, mid CBD and. Yeah, crossed.
Fluoro.
So you have crossed the stricture.
Yeah, now.
Huh? Looks like you have crossed the stricture. Huh? Fluoro.
Please keep it in center.
This is the hilum. So this is a common hepatic duct stricture other than hilar stricture, huh?
Let's see. We gradually withdraw and see. Hilum is intact, so good thing. Or it's a hilum. Before decision,
Hilum is fine.
making a decision that the hilum is intact, we again try to examine the entire CBD, because this is the point this will change the management entirely. Try to look at this side. This side. Is there any other opening or not?
नहीं, extreme movement.
Okay.
है.
Suction.
ऐसे extreme है पूरा.
Okay, we are slightly coming down.
Pull
Keep
out,
it in center.
Pull out.
But keep it in center.
हाँ, ये center ही है.
Okay. So
This
here
area-
there is a not much neovascularization, but I feel
I think it's a lobular mass-like
Yeah,
structure on the
mass-like
left of the
structure.
screen.
biopsy ले लो यहाँ से.
should we take it biopsy from here, or where we find a
So,
neovascularization?
This is also.
Yeah, I think the proximal area with all the blood and
and-
nodularity seem more.
I think proximal area is more rewarding, but I personally feel, please expert from moderator, I think hyla is patent.
Hilum is normal.
Yeah.
Yes, hilum is fine.
So I think that is the biggest. I think in MRCP it suggests that it involving the right and left hepatic duct.
No, I think it's a good point you're making, because what happens is oftentimes the MRCPs can overstage, or say, overstage the extent of the disease, which when we do cholangioscopy, you can actually change a patient from from extensive surgery. Now here it's going to be much easier for the surgical team to take care of this patient versus versus a tumor extending into the secondary radicals, which is not uncommon. And I think there are studies proving
See,
that
this is-
how
this is
cholangioscopy
lobular.
can impact
This is
and
the mass.
sort of downstage the tumor in that sense.
ये mass है ना. This is the mass.
So this is some lobular mass. Vessels are not there, but I still believe because of the appearance still from the mid CBD, it looks like malignant. Let's see again. Please keep it in center.
Yeah, it's complete center.
Somen, I think your best yield of biopsy is at an area which the mucosa definitely looks more abnormal. So, the proximal part where you're looking at could be
Yes,
sort of the
this area.
Yeah, the infiltrative part,
Yeah.
compressing the mucosa from outside may give you a negative biopsy.
Fluoro.
Because here the mucosa is infiltrated by the primary
यहाँ पे ले लो
pathology.
biopsy.
And I think that's where you should be
Yeah.
targeting.
Fluoro.
You have
So I think length of stricture is also quite high. It is starting from the mid CBD, extending up to the hyla, but hyla is patent. There is a significant neovascularization at the starting of the
Scope
stricture.
गिर रहा है, scope गिर रहा है, scope ठीक
नहीं.
करो.
Okay, keep it in center.
Because a lot of cholangios can sometimes have sort of infiltrative variety which goes inside the wall. And the mucosal biopsies can be negative in those patients. So where the mucosa looks bad, you take it from there, basically.
Maybe
And second, this
MRCP
is a
bad
naive
in those
patient. There is
cases.
no previous stenting also. So I think this looks malignant only. This is the best area I think to take a biopsy.
ऊपर से. So you can see some tortuous vessels superiorly. You can see at 12 o'clock.
I think biopsy forceps will come at 6 o'clock position. Now, just give me a.
Yes, sir.
So recently, when I reviewed this literature, this SpyBite Max has been researched and designed by our Indian team. This is the first endoscopic accessory that is designed by Indian team. Though it is
Sujata,
manufactured
no?
by Boston somewhere else, but the basic, the previously SpyBite legacy, you have to take a 5 to 6 chunk, and in this you just have to take 2 or 3 pieces, and the change in the design is from the cusp design to the just like a crocodile jaw type design. So this is SpyBite Max.
This is Max. Max, sir?
Ah.
Max.
So so I think this appearance is classically looks like malignant, but I personally feel even if it is malignant, you have to visually you can say it's 100% malignant. You should go for biopsy, for two reasons. For the as we are following the evidence-based
It's not
medicine,
coming out.
and second, okay. So you just stay there. Fluoro. So I am just pushing. Now try biopsy forceps.
Yeah, yeah.
Yeah.
Yes.
So this is another trick that if your forceps is not coming out or any accessories is not coming out, usually stuck at the band of the spice scope. So what you do, you just have to introduce your spice scope more inside. The curved portion will automatically become straight, and probably accessories will come out of the scope. Now we are coming.
Open.
No.
Wait.
Tell. I will tell you ना. We will
Wait.
take the best part.
No, वो नीचे 6 o'clock में एक area था, which was good. इसको थोड़ा अंदर लेता हूँ मैं.
Madam, I have to see my this position also endoscopic position. Okay, it's quite okay.
Yes.
Now open. Go this side. This side. Close.
Yes,
We are coming out.
Wait. The scope is falling. So give that.
This patient has a D1, D2 narrowing. So we have to cannulate in the extremely short position initially. So that may be the reason. And I am more to do ERCP in the prone position. And this patient is in supine. So this may be the two reasons that I am not holding properly. I think it is
Reduce
not too bad also.
थोड़ा reduce करो.
We have to inside it. Okay, like make it this though. Fluoro. Now I will reduce. Okay. Now open. Out. Forceps outside. Open. Good.
Yeah. लेना है ऐसा?
यहाँ से तो ब्लाइंड हो जाएगा.
रुको.
एक 1 minute. I will maintain a distance first. I will just or fluoro. Come down more. Now you just close the forceps. Close.
Give
Not so
this
easy
the
as
maximum
you.
position.
Yeah, I'm not.
Position
It is not about me and you.
ये लो, ये position.
I think sometimes Torkops go. Now out.
इसे lateral wall में ही आ रहा है.
We will. इस साइड नहीं आ रहा?
नहीं आ रहा है. It is the maximum है ये.
उस साइड करो.
बंद करो. ओके, forceps बंद करो.
We will go then inside. Let's see.
ये extreme है जो मैंने कर रहा हूँ ना. This is extreme. और उस it's not moving.
Any tips from moderator?
So
That
I
it will
was
be
asking
easy.
that if any up down movement or anything is helping there or not.
Up down
It's
movement
not
is helping
helping.
to proceed, but it is not helping to keep it in center or make a prominent lesion at a
तुम
6
करो,
o'clock
तुम करो.
position.
देखो,
We will-
करो, ये मुझे दो.
I think going ahead and coming back and taking it again, I think should help.
Going ahead and
Coming back again
okay.
and just
Let's
reposition it
start.
again.
Okay. Let's see. This you can take. Now
नहीं,
out.
ये इससे कुछ नहीं आएगा. ये तो ऐसा है.
This is mucus. Do you think?
Mucus. This is not tissue, no?
This is
Yeah,
mucus plaques.
Mucus है, mucus plug.
Yeah.
Okay, then we go further.
Wall से लेना पड़ेगा ना. You have to take bite from the wall.
Yeah.
आप ही रखो सर.
हाँ, देखा. ऐसा चाहिए हमेशा करता है ये तो. हाँ, ये इसे लो. ये वॉल से लो. ये यहाँ से लो. रुको, मैं डालता हूँ. हाँ, लो, open.
Yes, I think.
Vibes.
लो.
Yeah.
1 minute. I hope. Okay, 1 minute. Where is my scope? ऐसे तो मैं पकड़ जाऊँ.
आएगा, मुझे रेजिस्टेंस तो मिला हाथ में.
Where is my spy scope? Fluoro?
निकल गया क्या? तो
नहीं निकला नहीं है, but I think there is too much. I'm not able to see. हाँ बाहर आ गया. Let's again we have to go because there is a D1 D2. छोड़ो मासी, है ना?
खोलो इसको, खोलो.
Take me take. I'm going again. Give. Suction is on.
ये निकालो थोड़ा, ये निकालो कॉलम को, तभी सक्शन होगा.
Like में आया कुछ बायोप्सी में?
आया है.
आया है ना? So one chunk is
टिश्यू
there.
है. सुपाइन अप्रूव नहीं कर सकते पेशेंट को.
Prone कर तो सकते हैं ये.
लेफ्ट लेटरल कर लो ना, फिर भी इजी रहेगा. लेफ्ट लेटरल.
That's one bite we have received. It's a good chunk.
I think it is more difficult because that there is D1 D2 narrowing as well. Probably that's why positioning is very difficult.
Yeah, we have difficulty in negotiation initially. And I am, as told, I used to do all the ERCPs in semi-prone or prone position. This patient is supine. So, let's see.
So new learning.
Let's try. We have cannulated previously, so we can, rather than disturbing a patient. Okay, make it left lateral.
गाइड नहीं तो ये कर लो ना, गाइडवर दे लो स्फिंक्टोटोम से, इजी
ठीक
रहेगा.
है. Then we go for the wire guided. Give me a sphinctotome wire. So we can save the scope also. If prone you can do it, is the best thing for me. Prone थतो है तो करो ना. Semi prone क्या? Semi prone थतो है तो करो ना.
बस ठीक है. पैर निकाल दो, पैर निकालो. अभी देखो कितना इजी हो जाता है. स्फिंक्टोटोम दे दो. अल्ट्राटोम
We
दे
have
दो.
changed the position. Let's see what happens.
गाइडवर.
You have made it complete prone.
No, it is still left lateral.
Semi prone.
Okay, left lateral.
But
इसमें
still position is better, I think.
ऊपर फर्स्ट वाला ना, खींचो मत.
थोड़ा मासी.
So you are putting a wire and then doing it.
Oh, scope is.
ये तो उल्टा है.
Now it's a complete prone. માસી તમે આપ છોડો, હું તમને કહું ત્યારે પકડજો ને, કારણ કે રાઇટ નાઉ આઈ એમ ડુઈંગ મેનેવરિંગ, તમે પકડી રાખો. હા, this is best, but this is better position, much better.
Papilla in proper position, I guess.
No.
Okay, wire. I think this is we can easily now we can do fluoro exchange. Okay, we will do.
Yes.
Everything is comfortable. Anil, all okay na patient? Patient prone, sub parameter is okay na? हाँ, comfort. I think there is always a little bit of what we call a conflict even in endoscopy room, because most of the anesthetists are more comfortable in left lateral and supine position, and I used to do all ERCP in semi-prone or prone. So
is this patient intubated or?
No, this patient is intubated, sir. This patient is intubated. Okay. But even during even in propofol they are more reluctant. to do it in prone position, because sometimes some saturation drops or something happens, they have to immediately make him or her supine, and it is little bit of time consuming. So initially when I started my practice, most of the anesthetists are reluctant to go for ERCP in propofol in prone position. If they told me, if you want to go for a prone position ERCP, we are going to intubate the patient. And I have tried also that to do it in the left lateral and supine, but in I think around 10% cases I have to make them prone again. So I think now everything is settled. This is a classical papilla position. Wire.
I think now you'll able to do it in a proper way.
So now,
yeah. So
it is quite easy now. Remove the wire.
So very easy now. We can see.
Okay. I think even now biopsy will be also easier. So that's why that's what we have discussed, because we have to control three, means we have to vigilant for the 3 monitor, 4 wheels, 2 wheels of the upper J and 2 wheels of the spy scope, and 2 pedals. One is a irrigation pedal, and if you are doing a stone, then it's a laser lithotripsy or EHL pedal, whatever it is. So means it is quite its learning time is must be slightly higher for a single operator. And
so this is hilum.
So now this is hiram. What happens?
Take out.
Suction.
Khicho.
This is classical hilum, we can see. Okay, now we again come back. We will again examine the CBD.
Yeah.
Center, keep it in center.
Center hai, bilkul.
No, this is not. Now it is center. Now we are coming back. This is also a lobular mass, what we have seen previously. Now my endoscope is in much comfortable position. Even without touching anything, it is maintaining its own position in prone. And there is slightly D1, D2 narrowing also in this patient. I think this is area that we can take biopsy also. This is stricture area. Now again we will see.
There is lobular projection, so I think biopsy can be taken from here as well.
Let's again see downstairs. I think that was
fluoro dekha hoga?
Fluoro.
So we need to see the stricture level, no? Dekhao?
I think that what we have seen previously.
Yeah.
I'm just telling you, we have seen previously, is it mass or it is a mu? That's why I'm again re-examining.
Biopsies from here, some new vascular vessels are there.
So this is the abnormal area, I think.
Yeah, I think we should
above,
give it the biopsy first. But the learning point is highlights patent, and MRCP may overdiagnose. So I think that is the beauty of this procedure. I personally feel that even sometimes what happens, they ask in MRCP that the common hepatic duct is forming, and when you go and inject a contrast, you see the separation of the duct. So even in such a case, this can be used. Are you able to go inside?
No. Little bit.
And that is why the standard guidelines always says that the cholangiogram is important whenever you want to have the idea about the stricture pattern. Gram by any way.
Keep it in center. Yeah.
जा रहा निकल रहा है तो इसको थोड़ा इस तरफ जाना है.
Okay, so I have to change it from my scope position also. This is the main. Open.
Yes.
आगे जाओ थोड़ा.
This.
No, not from
I
here.
think I think close it.
Close.
It is also possible we did a CR in this patient. This is a nerve patient. After that, minimal ooze was there. So, what is audience opinion? This is a real tumor, or this is due to secondary to that blood clot, secondary to that CRE? Please come.
No.
Rajput sir is there. Saurabh sir.
No, I think they have left. But yes, of course, this blood could be there due to a dilatation which you have done initially.
I
That
think
is
we have
true.
to take
But then,
from
this area looks slightly abnormal. Vasculature is definitely there. So
I mean, थोड़ा सामने जाओ.
तो I think take from because
On this side. Yeah. Just want to take the biopsy from here. यहाँ पे रुको.
open. Bite.
Oh. Yeah.
Remove.
नहीं आया. Okay.
Again, reinsert.
रुको. Wait here. ये थोड़ा आगे जाओ. तुम थोड़ा आगे जाओ. स्कोप थोड़ा आगे लो. This complete.
What you can do, you can come here.
Just देखो इसको. Hold this.
You can come
जा ही
here.
नहीं रहा.
Hello.
We change the position. Sometimes change of hand will give a better result. Let's see.
yeah, sometimes when you get stuck, I think change of hand is
Every
needed.
possible permutation combination.
Irrigate. Sir, this is the pedal for irrigation. This yellow pedal.
नहीं wall में है.
Okay. Now we are in center.
पीछे थोड़ा पीछे आना.
That you have to come, na? पीछे
Yeah.
हाँ.
No, one from there, no? That vessels.
Okay, I think this is the best place, sir. Please hold there.
इसी wall में निकलता है ये.
And it is not about that. I think there is some different. You have to change the torque.
Wait. तुम निकालो इसको अंदर रखो. ये प्रोब अंदर लो. Yeah.
Irrigate. This is a better, much better. Keep it there.
इससे सेंट्रल लो.
Huh?
इसमें से.
This is range is over, na? इसका range.
That's what I was telling. That is fixed.
That's why I have changed, na? Sometimes it may be possible you torque from there and we can reach up to the. Or I think we can go to the lobular mass and we can take biopsy from there also.
Yeah.
So Sandeep and Saumin, you are doing a great job, struggling but not leaving it. That's a good dedication.
That's a good.
Yeah. So while you continue to take biopsies, we will start talk of Dr. Ramchandani, and once you are done with the biopsy, we will again show it to the audience. So Dr. Samir, please start Dr. Mohar Ramchandani's lecture, and I request the present moderators to be on stage because your live demonstration is one by Dr. Sandeep is still awaited. So present moderators, please be on stage.
I think we can take
Center.
out.
Thank you, Dr. Yogesh. Now we will move on to the next lecture, that is cholangiopancreatoscopy, future implications by Dr. Mohan Ramchandani. This is a recorded lecture, and for moderating the session, I'll invite Dr. Viral Vyas, Dr. Vivek Tang, and Dr. Dhaval Gupta on the stage. Can we start the lecture?
At the outset, I thank Yogesh for giving me this opportunity. I'll be speaking about future implications of cholangiopancreatoscopy. And as we all know, this is how the evolution of cholangioscopy has happened. First, uh, surgical cholecystoscopy was done in 1941, and then gradually we saw the first introduction of mother-baby cholangioscopy in 1975. Thereafter, there was a paradigm shift brought by single operator cholangioscopy, which was in 2007. And subsequently, now we are seeing more advanced digital based cholangioscopy. And now in 2021, there is first application of artificial intelligence in the field of cholangioscopy. So the future is bright for cholangioscopy, and I'll be speaking about some of the newer cholangioscopes and how therapeutic cholangioscopy is developing. We also have still some of the gray areas where we are struggling with indeterminate biliary stricture, where we want better tissue acquisition and we want less inter-observer variation in visually assessing a stricture. Of course, AI is now everywhere, and cholangioscopy is not left behind. And whether we are ready for ERCP to be replaced by radiation-free cholangioscopy. So this is the first cholangioscope which we use. That is the mother-baby cholangioscope, and it helps us in getting very good pictures. As you can see, once you see the stricture, the image quality is very good. But unfortunately, this type of scopes are very costly and fragile. So we were now thinking about why not to put ultra slim gastroscopes into the biliary system, which will give us a very high quality imaging and the therapeutic channel. We want a good therapeutic channel. The present therapeutic channel is 1.2, which is not sufficient for us to do therapeutic cholangioscopy. Say, for example, passing a APC probe to ablate, you can say, like vascular malformation in a polyp. Ultraslim gastroscope, of course, the image quality is the best, but you cannot stabilize yourself into the bile duct by ultraslim gastroscope because it's a bare scope and may tend to slip. So there are many balloons which are available which stabilize these cholangioscope within the bile duct, but still the passage of the bile duct passage into the bile duct by this ultraslim gastroscope is difficult. If you pass through the wire, you can only succeed in 50%. But as soon as you remove the cholangioscope balloon, you may fall out. So there is a lot of problem in step.